Christopher Balkaran here, the host of the Open Minds podcast. Folks, if you're a fan of the podcast, you'll know that I recently did a podcast with Dr. Kerry Bowman, and I have him here with me today. We're going to chat about two things, Kerry: vaccine certificates and MAiD. From your experience with Canada's experience with vaccine certificates, what did we do right as a country and what did we do wrong?
Well, with the pandemic and vaccines in general, Canada did relatively well compared to other nations. But I think we definitely went wrong in a few areas. And, protecting vulnerable people was one. And the people that really got the worst of it was people in long-term care and elderly people. I would also argue, and as would many other people, we did a terrible job globally of helping other countries in such a difficult time. But when it comes to vaccine mandates or passports, they were emerging, but we really as a country looked at them as sort of, as a way of dividing people, who's vaccinated, who's not, who's pro, who's against. And I think we really, really encouraged these divisions. We tended to demonize anyone that didn't want to be vaccinated. We stopped listening. And, to create these cleaves in society, they don't go away. They tend to deepen. And I think we've seen a lot of that since, the worst of the pandemic. So I think we were much, much too extreme in insisting on and pushing with vaccines. I'm absolutely pro-vaccine. I really, really am. But if we believe in free will and if we believe in the rights of the individual, you just have to accept that not everyone saw it that way. And we were so judgmental and aggressive towards people that weren't on board.
Kerry, it's so interesting you mentioned that because you'd think that policy professionals would have known that, and politicians in particular, when they're going down some of the rhetoric and the demonization. Why do you think they still went down that? Was the push to get people vaccinated that great that they said we need to make this as black and white as possible?
There's that. And at the risk of sounding a bit cynical, I also think people in leadership, politicians, hospital CEOs, those types of people wanted to be, it was a national and global crisis, and they wanted to be seen on the right side of history. And the right side of history was to be absolutely, aggressive in terms of vaccination. And, vaccinations were wonderful. They saved a lot of people's lives, but they weren't really what we were told. I mean, vaccinated people still got COVID. Most of us ended up getting it. And, it didn't mean that vaccinated people, couldn't get COVID, couldn't transmit COVID. So we made it very, very black and white and very, very categorical. And in a lot of cases, things that we weren't sure of, the collective we is our governments and public health, really took positions of much more black and white. And I don't think it did us any favors at all.
You mentioned those social fissures don't go away. What have you seen? I'm sure all of us have seen those fissures play out, but how can we kind of heal and move past that? What can leaders do to kind of rectify some of those fissures that were created?
Well, again, not everyone would agree with this. I actually think we need a national inquiry into the pandemic. Now, I know this country's had many national inquiries, and many people are going to roll their eyes at the suggestion, but we really did a very terrible job of protecting elderly people, particularly in long-term care, and people died because of it. And I think we also did a terrible job globally. And we had some strengths. But, was that the last pandemic for a long, long time? I don't think so. And I think we could have another pandemic. I'm not saying we will, but, H5N1 is bubbling in our background and we don't know. And so are we well prepared for another pandemic? I would argue we're not, because if we don't learn from our strengths and weaknesses, we're likely going to repeat it all over again.
Professor, I'm going to do a bit of role play with you on this. Say you're the top advisor to the Prime Minister and H5N1 is rearing up. What would your number one, top three pieces of advice be to the Prime Minister and the Premier even on how to handle a type of global pandemic like this again?
Well, first, I wouldn't have the qualifications to know what everybody should do. But what I would say is let's be much more transparent about what we don't know. And let's be much more respectful of the fact that there's going to be differences on this. And let's find out who's vulnerable and let's protect them from the outset. Rather than pretending we're going to, let's really protect the most vulnerable people, not just nationally, but globally.
And for our global commitments, it's also looking at the most vulnerable countries where Canada can play a very important role as well.
Well, remembering that many of those countries never got vaccines, some of them hardly at all. I was in Yemen in 2021, and you had less than 4% of the population had even had access. We talked about it a lot, but we really, really didn't deliver at all. Pandemics, by their very nature, are going to be global. They're not going to sit in one country. And so we really didn't do a good job of thinking globally on this.
Professor, I truly admire your medical ethics approach, and I would be remiss if we didn't chat about medical assistance in dying, a topic many of my followers and many people who have listened to the podcast know all too well. We've been doing deep dives on this topic. You and I chatted about this. Professor, one thing you said to me yesterday was 70% of those with severe mental health illness are unemployed. And I'd love to know.
Through no fault of their own. Yeah.
And that's interesting. And so, how does that translate to MAiD and the decision for MAiD as well?
Well, in this way, of the people that are unemployed through no fault of their own, because they're just too impaired to maintain employment, a small percentage of those people are going to have a safety net of family, perhaps, or something, and the majority are not. So they're going to be vulnerable in terms of housing, in terms of food security, in terms of a lot of things. They're going to have tremendous vulnerability. And, it's very hard to tease apart when there's a request for medical assistance in dying. Is the driver the underlying illness, or is the driver the underlying illness and the social context of I'm about to lose my home, or I've already lost it? I can't even afford, I'm at food banks all the time lining up. I can barely make ends meet. So what happens with that 70% is the vulnerability just escalates in an incredible way. And again, that's through no fault of the people involved.
Professor, I remember reading somewhere that it's actually in BC, it's 90% of those with severe mental illness are unemployed. It's a really high number. And I remember reading that the progression of illness for those with terminal cancer follows like a linear progression, but those with a mental illness fluctuates. And there are episodes of severe depression, but then there's also times where it can break a little bit.
Yes.
Would you agree with that? Because I find while I was reading that, it may do a disservice to those with mental health illness.
The fluctuation, you mean? Yeah, so certainly with depression, there's fluctuation, and with many mental illnesses, there's fluctuation. And I think one of the things that gets lost in the public conversation about medical assistance in dying and mental health and mental illness is that no one is talking about potentially, because we don't have this yet, but potentially providing access to medical assistance in dying when a person is acutely ill, in the throes of depression, in the throes of a psychotic episode, those types of things. What we're looking at is for the people who ebb and flow over the course of a very difficult life and say, I just can't do this anymore, who are not in an acute state. That is the question we're looking at.
And Professor, on that same topic, I know these are very big topics, folks, and I encourage all of you to check out the podcast I did with Kerry Bowman because we go into all of the detail. But Professor, we talked about autonomy of the individual. And when you're in the throes of severe depression, one can question whether or not your full autonomy is there. What would you say to those who would argue that severe depression, you lose a bit of autonomy? You don't have the right anymore to determine MAiD.
Many people within the field of mental health would say that as a person over the course of a lifetime ebbs and flows through mental health challenges, that they have a very, very hard time forecasting any kind of positive life in front of them, and therefore they should not be eligible. But here's the thing, that runs very close to paternalism and essentially is paternalism. I know what's best for you and you don't know what's best for yourself. And when a person says in a sustained way over the course of many years through ups and downs, I can't do this anymore, I think that is something we have to deeply, deeply consider. And could there be some incredible breakthrough in mental health treatments that suddenly surfaces? I guess it's possible, but it's not very likely. And even then, if they are truly informed, they know that too. So what I worry is paternalism. In Canadian society, autonomy is really powerful, and I think that gets missed. So people would say, well, that's true of all Western cultures, and it is, but it's especially true in Canada and under the Canada Health Act. And the reason we have medical assistance in dying is because of our belief in self-determination of the individual. And to declare someone incapable, like you're not capable anymore of making your own decisions, In the absence of criminal activity or something, it's really the loss of human rights as well. It's your freedom as an individual. I see mostly the mental health challenge in relation to what's often associated with the social factors that come with mental health challenges. Because to fundamentally say the kind of suffering that one experiences with advanced metastatic, meaning advanced cancers, that suffering is unacceptable, but mental health disorders, that's acceptable, or people should learn to live with that. I think that's hard to justify, but I see the greater challenge not so much in the autonomy, it's in these powerful social factors. Mm-hmm. And I've said this before and I say it again. A lot of us, including me, were fairly naive in the early days to believe that we could just kind of parcel off these complex social problems and do these great independent assessments and be very clear on what we were assessing and the decisions we were making. I think we were quite... In fairness, I'm not sure I was the most naive, but I'm definitely in that club.
Professor, it's interesting you mentioned that because in the 5th annual report, the reason 95% of folks select MAiD is due to psychosocial reasons, feelings of isolation, feelings of loneliness, feeling like they'd be a burden to their families, loss of bodily function. And I recognize there are treatments for these, treatments, I use in quotations, that are not necessarily being offered to the patient. In some cases that have been found. And that, some have said, is why the number of MAiD cases are rising. It's that it's rising so dramatically because we're not offering those mental health supports. Would you agree with that assessment, or do you think that's a bit much?
It's very hard to tease them apart because, when I work with patients, so I've been directly involved in many MAiD cases, and I'm also a former medical social worker. So when people say, they've got ALS, a debilitating illness where they're losing more and more function, when they say it's this social isolation that they fear, they're not just saying social isolation in general, they're saying social isolation in relation to the illness. Mm-hmm. Like, I used to go out every day, now I can't. I used to do this, manage the stairs, I can't. So it's in the context of the illness. So it's very hard to then say, because I know those surveys, they're not saying, it's often in the context of the illness. So that is what worries me. But I absolutely do think that if we're going to be fair and ethical with MAiD, we have to be able to offer supports, mental health supports, reasonable housing and food security as a baseline. And at this point, we're not doing it very well. So that's where the complexity lies, I see.
Professor, the very last question, I know it's very cold out, but the last question I have for you is on housing and in its relation to MAiD. I remember reading a report talking about housing being a major factor for some in their selection of MAiD, and I think that's foreign to a lot of people. Why would housing be one of the factors in MAiD?
Well, because it's crazy expensive, and people are already struggling, and people that are struggling with illness or mental illness are the finances of coming up with $2,000 or $3,000 a month is just absolutely overwhelming to a lot of people. And then housing interfaces with food security because so much gets tied up in rent, people don't have access to food, or they don't have access to healthy food. And their lives become more and more circumscribed. So the housing crisis is very much tied to MAiD, and it seems to be getting worse, not better. So these are all factors we have to give deep consideration to.
Professor, I can't thank you enough for your time. Everyone check out our podcast we did yesterday together, and this has been incredible. This hopefully sheds some more light on vaccine certificates, MAiD. Folks, I'm going to keep doing deep dives on medical ethics and bioethics because it's so important to our society, and I can't thank you so much for all your research and work in this field.